Hello and welcome back to Therapeutics. In this block, we're going to talk about COPD management. Our goals will be to look at the common treatments for COPD in particular. And really what we're going to do is look at the 2023 GOLD guidelines. I'll talk to those in a minute. The new guidelines, the Global Strategy for Diagnosis and Management and Prevention of Chronic Obstructive Pulmonary Disease, this is a body, an international body, that has really worked hard over the last 2 or 3 decades to standardize the approach for the management of COPD, looking at how we can tweak therapy and our approaches to therapy, both diagnostically, how we work up patients, and then what are the pharmacologic and non-pharmacologic interventions that have the best evidence. And these were revised, they get revised every year, usually published either in late December or early January. And there are some revisions in the 2023 guidelines that really are somewhat simplified over the 2022 guidelines. And so I really took the opportunity to look at their slide set, their teaching set, and identified that they did it much better than I ever could. So with a couple of modest exceptions where I might add a few different slides, I'm taking their entire slide set and I will speed up or slow down in their slide set for things that I think are particularly pertinent for you to be aware of. So they often, like most guidelines, will demonstrate the levels of evidence that they utilize and how they come about determining that level of evidence. And so obviously we're looking at levels of evidence that are the strongest, and so we like to sort of make guideline decisions primarily based on what they determine here as level A evidence. But level B evidence often provides us useful information and may guide our therapy as well. The guidelines go through the FEV1 trajectory over the course of a person's life. I'll leave this content primarily to the ClinMed faculty to work through with you. Similarly, there are a number of proposed changes in nomenclature or taxonomy that have been adopted by the GOLD guidelines for 2023. As you look at these, there are establishment of whether someone has an alpha-1 antitrypsin deficiency. There are other sort of aspects of COPD that are addressed as well, particularly abnormalities in lung development, environmental abnormalities, which we classically really only used to think about primarily as cigarette smoking, but also pollution exposures, environmental exposures, employment exposures, and we think of not only classic tobacco smoking, but also vaping, e-cigarette use, and cannabis use as well. In addition, they talk about COPD secondary to infections, particularly tuberculosis and or significant frequent childhood infections. There's an overlap between COPD and asthma, and then they have a nomenclature for COPD of once you've ruled out all those other factors of an unknown cause. They also look at clinical indicators for when you might consider a diagnosis of COPD, particularly dyspnea that is progressive over time, worsens with exercise, and is persistent, with a recurrent wheeze, may have a chronic cough, have recurrent lower respiratory tract infections, and patient with a history of risk factors. They outline the other causes of a chronic cough that are probably in your differential, both intrathoracic and extrathoracic. They also look at, in the differential diagnosis of COPD, ruling out asthma, or there might be a comorbid state with it, heart failure, bronchiectasis, tuberculosis, and then some other factors listed down near the bottom as well. Considerations of when to do spirometry is listed in this slide. I'm not going to go through that, but it's available in the guidelines and in this teaching slide set. They also will talk through a normal tracing for what spirometry would look like and what airflow obstruction would look like on spirometry. The role of spirometry is outlined in the guidelines as well, both for the diagnosis and assessment of severity and periodically as a follow-up assessment in evaluating how to approach a patient with COPD. They have 4 grades of severity of airflow obstruction. Gold 1, 2, 3, and 4. These have not changed over the last decade, and they are defined as the FEV1 divided by the FVC, and the determination of the FEV1 as predicted. Is it greater than or equal to 80% of predicted, or categories 50 to 80, 30 to 50, and below 30? When we're looking at symptoms for patients, you're looking at some simplified, hopefully, way to assess the severity of someone who has dyspnea. And the modified MRC dyspnea scale is pretty much the one that I think most clinicians gravitate to because it's pretty simple. And someone in a single sentence could describe to you what their degree of dyspnea is on exertion, and you could categorize it pretty simply. So this is really, I think, the scale tool that clinicians will look to use. A slightly more detailed assessment is the CAT scale, which is listed here. Those could be used, for example, in a questionnaire for patients when they are waiting to see you in practice if they have COPD. Or you're concerned about COPD with them. That's also useful. Again, more detailed, but just a bit more cumbersome for clinicians to use. Prior to the 2023 guidelines, these older 2022 guidelines are now outdated. These guidelines went through a process of spirometry confirmed diagnosis, which still is in the guideline. They went through the assessment of airflow limitation, or the grading of gold 1, 2, 3, 4. That also has not changed. But what has changed is what's in box number 3. We historically used to categorize patients who had COPD as either in box A, B, C, or D. That if they had mild symptoms, they were either A or C, meaning a low MRC score or a CAT score, or if they had a lot of symptoms, they were B or D. And the determination of whether they were A, B, or C, D had to do with whether or not they had frequent exacerbations, either more than 2 exacerbations in the prior year, or 1 or more that led to a hospital admission. The 2023 guidelines is identical with the exception. They have merged C and D. If you have had an exacerbation, really more than 1 exacerbation, or any one that led to a hospitalization, you are immediately put in category E for exacerbation. The old C and D categories are gone. So when we get to the therapeutic options, we do have a specific option for A, a specific option for B, but now there's a merged option for everyone else who's more severe, who does have a pretty significant exacerbation history, and we'll walk through that. So as you look at this, there's also diagnostically data for when to use a CT in stable COPD. I'm going to defer that to your ClinMed faculty. And there are strategies also for getting patients to quit smoking. This is a big deal. Smoking cessation is the number 1 goal for any patient with COPD. Before we even start to add on interventions or have them do non-pharmacologic therapeutic interventions, the first non-pharmacologic or even maybe considered pharmacologic intervention is to stop smoking. This is a big deal. This is also very hard for patients. So you want to be like a dog with the bone with this. You want to ask them systematically at every single visit where they are with their tobacco use and their smoking. Strongly advise or encourage them to quit. Assess their willingness and their rationale for continuing to smoke versus quitting. Do whatever you can to help them do that and arrange a follow-up contact with someone who might be able to help them do that. For our pharmacologically mediated or assisted, I would better say, smoking cessation, the main one we use in healthcare systems in the hospital is one or more different nicotine replacement systems. These can be transdermal, they can be gum, lozenges, there's even an inhaler that's available. And this is the most common modality we use in the hospital because it's pretty simple for us to put on a nicotine patch and give patient nicotine gum or get nicotine lozenges while they're in the hospital. Hospitals and healthcare centers universally are no smoking zones. That includes vaping, all of it is not allowed in any hospital. So patients often who are smoking and then get admitted to the hospital are miserable. And so we offer them a nicotine replacement, which most patients will gladly accept, but would really rather continue smoking, maybe. Um, but if they've had 4 or 5 days where they have not smoked and they've started nicotine replacement in the hospital, plus, they've maybe just had a COPD exacerbation, which is the reason for the hospitalization. They may be a little more motivated to continue smoking cessation at the end of the hospital stay. So nicotine might be a big part of that. The other two options are bupropion or Zyban, oral antidepressant. We talk about this in behavioral medicine as well, but Zyban or bupropion is an antidepressant, primarily affects norepinephrine, and it's a great drug for smoking cessation. It's a good antidepressant when someone needs a little bit of energy boost. But the downside is that bupropion poses a risk for seizures for anybody who has had a history of seizures or withdrawal seizures from benzos or alcohol withdrawal. So you don't want to give bupropion to those individuals. And if anybody has a lot of underlying anxiety or insomnia, bupropion is not a great choice as well. The third option is Chantix, which I believe has actually not been available. It's been on national back order. There's been some concerns about the availability of product and so it's not. I think there's been some difficulty in patients even obtaining it. It's an agent that's a partial agonist-antagonist at the nicotinic acetylcholine receptors. It's associated with also some modest risk for suicidal ideation and other problems with it as well. I just don't see people using Chantix now, but I think a lot of that also has to do with availability. Here's a chart of some of the other options that are listed here, but probably the most important variable to consider with any of these pharmacologic options is to make sure there is either individual group support, helplines, online assistance, something. And most states have a smoking cessation hotline program. Many insurance companies also have support groups for patients as well. I'd encourage you to sort of make sure patients have all of those things available to them. As we dig a little further into the guidelines, they have a lot of recommendations in these guidelines that are very sort of common sense things to think about. One of them is vaccination status for someone with COPD when it's stable, and particularly those conditions for which there's a vaccination available and they have a pulmonary consequence to them. Those are particularly the vaccines that you want to make sure people are up to speed on. They include the annual influenza vaccine, the likely soon to be annual COVID vaccines, but whatever they are in the primary series and boosters, they should be up to date on those. The pneumococcal conjugate vaccine, the new PVC20 vaccine that's been available as of 2022. And then whatever other vaccines are recommended, particularly Tdap, particularly as it relates to pertussis. They also recommend making sure that the shingles vaccine, at least for patients over 50, but there's also now guidelines from the CDC for the shingles vaccine for anybody who's otherwise immunocompromised or has other severe health limitations. So all of the vaccines are critical for really all patients, but particularly your COPD patients. There are a lot of commonly used maintenance meds, and what I'd encourage you to do is we won't spend a lot of time on this particular slide, but notice that what we're generally going to use in someone with COPD is usually a long-acting antimuscarinic. And in this day and age now with the new guidelines for most patients, we use the combination of a long-acting antimuscarinic and a long-acting beta agonist. And then we consider adding on inhaled corticosteroids in those category E patients who have a high eosinophil count or a moderately high eosinophil count and have failed just long-term beta agonist and long-term antimuscarinics. But there's a lot of other sort of options that are listed here. The methylxanthines like theophylline, no one really uses much anymore, although occasionally we see pulmonologists may choose that to use with patients. We talk about the phosphodiesterase inhibitor that's very limited in use because of its adverse effects, but actually the phosphodiesterase inhibitors probably work quite well in patients who have severe category E COPD. We'll talk about that's role in just a couple of minutes. And finally, the mucolytic agents, for which really these international guidelines really focus on N-acetylcysteine, but the mucolytic agents I see pulmonologists using all the time is sort of a lower tier mucolytic, which is not addressed in these guidelines, is guaifenesin. So important, I think, to look at all of the things that are going to assist patients in your toolbox and to know with the GOLD guidelines where they really will fit for your patients. The bronchodilators in stable COPD are listed here, and primarily we have more data for the LAMAs. If you see the 1, 2, 3, 4, fifth bullet down, that the LAMAs, the antimuscarinics, have had a generally greater effect than COPD than the LABAs do, but the combination and the one right above it, the LAMAs and the LABAs together do more than either one alone does. And so we see that helpful. In addition, the short-acting beta agonists and the short-acting muscarinic antagonists are helpful in acute episodes as well. So the bottom line here is that we really do look at where the maximal therapy is for patients, and things are really moving toward the combination of a long-acting beta agonist plus a long-acting muscarinic antagonist long-term to reduce future exacerbation rates, and there is a role for as-needed SABA or SAMA therapy as well. There is, if you scroll down near the bottom of this slide, you'll see that theophylline, while it does produce some potential benefit, it is not considered a first-line option for patients. The anti-inflammatory therapies, here we'll talk about them. The inhaled corticosteroids make sense, particularly, and we'll talk about this in a bit, for patients who are already on a LABA and a LAMA, and they have elevated eosinophil counts. So we'll talk more about where those fit in the next slide. But they do make sense to consider for folks who in category E who have particularly a high eosinophilic component to their COPD. Oral glucocorticoids and systemic IV glucocorticoids make sense, but not necessarily long-term. Really, we're talking about short-term therapy, not long-term therapy of oral corticosteroids. So they're not in stable COPD, but only in exacerbations. The phosphodiesterase 4 inhibitor has a role in patients with moderate to severe exacerbation risk, but there are side effects that need to kind of be addressed. And usually the phosphodiesterase 4 inhibitors are initiated by the pulmonologist, usually not by somebody not from the pulmonary office. We'll talk about antibiotics for acute exacerbation as well as preventing future exacerbations. There is ongoing data for the last decade that long-term azithromycin, for example, reduces future exacerbations in high-risk patients, but that's associated with bacterial resistance as well. The use of mucoregulators and antioxidant agents has some modest benefit. It's not really a main line of therapy. And N-acetylcysteine is pretty awful because it smells like rotten eggs. So I'd sort of defer. Many pulmonologists that I work with will use guaifenesin, partly, even though it's maybe not as effective as N-acetylcysteine, it will also at least help as an expectorant to loosen things up. Not quite mucolytic, but it will be offer to loosen things up a bit. And finally, there is some evidence about the use of statins in preventing COPD, but there's no data to say that if you don't have another indication for using a statin, using one in a patient with COPD is, there's not enough evidence to support that. So when we're thinking of a patient who might be in category E, for example, they might already be on a LABA and a LAMA therapy, and you're trying to decide whether or not you want to add an inhaled corticosteroid. Who are the candidates for adding a inhaled corticosteroid to their LABA-LAMA therapy? And these really are patients in green who have a history of hospitalizations for exacerbation, particularly if they've had more than one or two, or they've had more than two or equal to two exacerbations of COPD in the prior year. But particularly if their eosinophil count is high, over 300, and or if they have concomitant asthma. Anything less than that, you're kind of weighing the pros and the cons. And the problems with inhaled corticosteroid primarily is that if you have a low eosinophil count below 100, you're typically not going to benefit all that much from adding an inhaled corticosteroid, and you are going to increase the risk for a future pneumonia. And so we're going to avoid inhaled corticosteroid if you've had a history of pneumonia or frequent pneumonias, or you've had a history of mycobacterial, particularly tuberculosis infections. Again, we're going to steer away from inhaled corticosteroids. The evidence that supports pharmacotherapy and non-pharmacotherapy long-term at reducing mortality. So here in the drug therapy, that decreases mortality pretty significantly, and why the guidelines have been updated are that the category E patients who are really with a high eosinophil count, the addition of maintaining LABA and LAMA in inhaled corticosteroids offers some benefit on reducing mortality. And the non-pharmacologic therapies, by far, smoking cessation is big, but there's also benefit, particularly for category B and E patients, for pulmonary rehab. The role of oxygen therapy and the other modalities that are listed here, non-invasive positive pressure ventilation and lung volume reduction surgery, have roles as well. I'm going to defer those to either the pulmonology team and or the ClinMed folks in your faculty. Other pharmacologic treatments that are considered, and again, particularly alpha-1 antitrypsin, is usually going to be an assessment that's done as part of the pulmonary workup initially, and then the intravenous administration of alpha-1 antitrypsin is going to be really a decision by the pulmonologist. He's going to need authorization for coverage of insurance. There's a lot of issues with, acquisition of alpha-1 antitrypsin. That's in the domain of the pulmonologist. There's no evidence that antitussives per se offer much benefit. Dextromethorphan, for example, is not going to really help people that much with COPD. Vasodilators don't really help either and may actually worsen oxygenation. Other issues they recommend: pulmonary rehab, particularly for patients which they look at in category B and above, they'll recommend that. Self-management, shared decision-making, education is important, and integrating care in is always kind of important, but they haven't really demonstrated that the addition of telehealth offers more than just standard therapy at this point in time. When you've got somebody with end-stage COPD, there's often a consideration for palliative care, end-of-life care, hospice care. And in those scenarios particularly, even though it seems counterproductive, opioids are a common modality to improve a patient's sense of breathlessness. There's also other factors that are considered here, and we defer those to, again, the palliative care teams. The role of oxygen therapy and ventilatory support, again, important. And usually what we'll try to do with oxygen, and there's a slide here in a bit that will talk about goals of therapy, is usually we look at oxygenation to get them hovering around a 90% if that's possible. But a lot of these folks with COPD might do pretty well even if their oxygenation, they might live at 88%. Or so, but usually we try to shoot for up to 90%. There are, recommendations that are specific for surgical or bronchoscopic interventions with COPD. These are, again, you're going to probably refer these to the pulmonologist for these. And the interventional therapies, again, all in the purview of the pulmonologist: lung reduction surgery, blectomies, who's a candidate for a lung transplant, bronch interventions are also, again, under the role of the pulmonologist. So let's kind of take a step back here and look at the overview of our management of a patient with COPD. Per these guidelines, you're going to start with the diagnosis, based on symptoms, risk factors, and spirometry. You then make an initial assessment. What's their FEV1? Are they gold category 1 to 4? You need to look at their exacerbation history as well as their symptoms. For example, the MRC 0 to 5 scale. You want to check their smoking status. You want to rule in or out alpha-1 antitrypsin deficiency and other comorbidities like heart failure, pneumonias, some other things that could sort of contribute to are important in the assessment. Then you look at the initial management. Based on the gold, A, B, or E categories, you're going to see whether everybody's a candidate for smoking cessation, everybody's a candidate for vaccination, everybody's a candidate for active lifestyle. The initial pharmacotherapy will be based on A, B, or E categorization. You're going to do everything you can with self-management education, and you're, of course, going to manage the comorbid states as well. And then you're going to review how they did with all of that. So at the next visit, you're going to see, okay, we did all these things with additional management. How did they do? So going through what are their symptoms now, 4 weeks later that they've started this intervention, whatever you've done, how many exacerbations have they had? How's their smoking cessation going or not going? What are the other environmental risk factors? Did they use their inhaler correctly or inhalers correctly? What type of physical rehab and pulmonary rehab are they doing, if any? How are their self-management skills and what's their status on vaccination management, comorbidities, and then getting an annual spirometry on them. And then as it's out of list, you kind of readjust things. That's basically everything to do with COPD. The remaining slides here will talk a bit about more specificity or more which therapy you pick under which category or guidelines and the advantages and disadvantages of those therapies. So Keeping in mind our goals. Our goals for patients are to both reduce symptoms, and reduce risk. And so we're going to really have both of those are going to be part of what we're doing. Historically with COPD, we did everything we could to reduce symptoms, but didn't know that we're doing that much to reduce risk. The biggest thing that's going to reduce risk is and slow down the progression of the disease is smoking cessation. And so the gold criteria and every set of guidelines for the last 30 years has really emphasized the importance of that. So tobacco cessation, critical. There are sort of steps that are listed here, but you're going to do everything you can to get them to stop smoking. You're going to also identify other factors that, in addition to smoking cessation, pollutants. Is there something in the home? Is there a wood stove? Is there, something else that is a risk factor for their COPD? Other things you want to confirm is that they know how to use their inhaler. Most patients will do perfectly fine in an inhaler, do not need a nebulizer. At the home setting, you want to make sure, however, they know how to use their inhaler appropriately. Most of the time these days, you're trying to have them manage with the fewest number of devices possible. So if you're giving them a LAMA and a LABA and an inhaled corticosteroid, there are products available now that have all three in one inhaling device. Makes it easier for them and everyone else. They're pricey, but the individual inhalers are pricey as well. You want to make sure that they know their device is appropriately matched for them and they know how to use it appropriately. I'm going to defer this slide that you could stop and read more at your detail if you'd like. And the key things with bronchodilators are, for the most part, we're looking at LABAs and LAMAs over the short-acting agents, with the exception of immediate relief. And that we typically look at LAMAs over LABAs if using one alone, but more data really is coming out about the combination of a LAMA and a LABA together. The anti-inflammatory agents that we don't recommend monotherapy at all with inhaled corticosteroids. That we recommend, that's different from what we see in asthma. Asthma, you could use inhaled corticosteroid, if folks are early on in asthma without using a long-acting beta agonist at all. But that's not true with COPD. COPD, you really want to use a LABA and a LAMA together and then add the inhaled corticosteroid to that. So that's pretty much the case. The other issues that they'll look at here are to look at whether or not the patient's a candidate for a phosphodiesterase inhibitor. At least up to 2023, these have really been in the domain of the pulmonologist. I think that the GOLD guidelines are starting to say that the phosphodiesterase inhibitors may have a slightly greater role than historically they've had, even though they have adverse effects associated with them. But that said, they're still quite pricey. You're probably going to need a pulmonary consult and a prior auth to get them anyway, so they really do fall under the domain of the pulmonologist. In addition, there is a role in former smokers primarily to look at long-term macrolides, but the decision of adding azithromycin long-term for a patient, probably because of the issues of antimicrobial stewardship and who's a candidate, and these folks are probably having symptoms that are significant enough, that decision ought to probably be made in consultation with the pulmonologist as well. And then statins and beta blockers aren't recommended, but at least in the case of statins probably offer some benefit if you have a comorbid condition for which a statin makes sense. Other issues that they talk about here are the role of alpha antitrypsin. They don't recommend cough suppressants. They also are careful about the role of the treatments for pulmonary hypertension in folks who have COPD. And again, that's under the domain primarily of the pulmonologist. Again, and lastly, don't be surprised when you see low dose, long acting corticosteroids in folks who have a lot of breathlessness and COPD. We're going to be careful about how we do that. Those are usually the category E patients who are pretty far along in their disease, and most clinicians would not feel comfortable in ordering a long-term opioid for a patient with COPD unless that decision came from pulmonology. But still, there is some data for patients who are really breathless, feeling breathless, that they're having issues. Okay, here is a bottom line key therapeutic slide. For patients who have or category A are 0 to 1 exacerbations in the last year and have not had any hospitalizations. Categories A or B being more symptomatic, they maintain on a bronchodilator. Most folks will just start them on a LAMA, but now even group A, it's not unreasonable to start them on a LABA and LAMA combination. This is new in that we only looked at a LAMA for category B in the past, and now we're looking at LABA and LAMA therapy together. That combination now in COPD. And you could argue that either a LAMA alone or a LAMA plus a LABA together, even in group A, makes sense. Okay? If you get up to group E, you are again doing LABA and LAMA therapy, and then you're adding on inhaled corticosteroids if their eosinophil count is above 300. Okay, that's our first step. So this is a real key slide, and I've got a couple others that I think are more key slides as far as therapeutics go, for you to kind of remember that in deciding who gets what therapy. All right, so how do you manage it? You review their symptoms, how many exacerbations they've had. You assess how they're doing, what's their inhaler technique, their non-pharmacologic approaches, as well as their pharmacologic approaches, and you adjust, tweak things, and you keep reviewing it. That's kind of a standard approach. Here's a second key slide about follow-up. So they differentiate in the goal guidelines whether or not your primary presentation is dyspnea or exacerbations. If it's dyspnea but without exacerbations, it's LABA and LAMA. You could start with a LABA or a LAMA. The data really is a LAMA, not a LABA. But most folks will go right to, with the new guidelines, probably a LABA and a LAMA together. And then looking at maybe tweaking that as it needs to be tweaked. If you've gone only a single agent, maybe switching a device or switching a product that may work a little better or not better, as well as doing all the non-pharmacologic things or auxiliary things we talked about doing. With exacerbations on the right side here, it's all the same, except you're looking at their eosinophil count initially, and if the eosinophils are greater than 300, you're adding inhaled corticosteroids. If it's less than 300, initially you see if they can be managed with LABA and LAMA alone, but if they're failing that and their eosinophil count's above 100, they're then recommending adding an inhaled corticosteroid. And if their eosinophil count is less than 100 and they're on LABA and LAMA, then the pulmonologist is going to evaluate, are they candidates for a phosphodiesterase inhibitor and or azithromycin. Okay, so that's kind of helping you differentiate, LABA, LAMA, and then inhaled corticosteroids. Again, eosinophilia primarily, but you're looking at if your eosinophils aren't all that high and you failed LABA and LAMA, add it, and then when do you add other interventions? All right, here's our third key slide to think about, is the nature of group A patients and what they get. They get smoking cessation, they get physical activity, they get a bronchodilator, and they get flu vaccine, pneumococcal vaccine, pertussis vaccine, COVID vaccine, shingles vaccine. And B and beyond get all the same. These are all non-pharmacologic, but they also are candidates for pulmonary rehab. So important for, I think, for you to figure that out, okay? That pulmonary rehab from B on is now a recommendation. All right, some other non-pharmacologic issues here. Again, self-management is a key issue for patients, so you want to pay attention to that. The role of supplemental oxygen. Typically, what you're going to shoot for is to look at supplemental oxygen and titrate to an SaO2 of about 90 or greater than 90. I'm going to defer to the Clin Med team, but typically, 88 to 90, depending on where they are, might be fine for them. You don't want to overshoot the oxygen for two reasons, and I'll defer that again to the clinical med teams. But one is the risk for affecting respiratory drive if they have a lot of CO2 accumulation, and B, oxygen itself is in a sense toxic to tissue. So you want to be kind of aware of the risk benefit of oxygen status in patients and what we do with that. The surgical and interventional therapies and advanced emphysema are listed in this slide beyond the scope of what I'm going to talk about. And there are key points for non-pharmacologic treatments. Again, these have kind of been reiterated once before, but the values and the goal sets are education and self-management for patients, really share decision-making, have them take ownership. Making sure the vaccines are up to snuff, adequate nutrition, addressing whether there's end-of-life or palliative care approaches that make sense for them, and when is that needed to be done, how you manage the treatment of hypoxia, how you manage hypercapnia, and interventions for when they need a bronch or they need a surgical intervention. The other things that are listed include co-founders. You're going to, what's in your differential or what's kind of complicating their presentation of COPD. Probably the most common is a combination of pneumonia and their COPD exacerbation. But you've also got to be thinking, could this be a PE when they come in the emergency department? Is this an exacerbation of their heart failure? Is it neurothorax? Is it even an MI? And then assessing things, they talk about sort of a standard approach to assess and a standard diagnostic and assessment approach. They list guidelines here. They also look at classifying the severity of a COPD exacerbation. And in the more severe COPD exacerbations, they'll talk about a more aggressive management and whether or not that warrants hospitalization for the patient. Potential indications for hospitalization are listed here when they have severe symptoms and or acute respiratory failure, particularly if they have significant physical signs of cyanosis or edema and other serious comorbid states. When they are pretty severe but not considered life-threatening, the approach is going to be to look at getting all the diagnostics that you need, give supplemental oxygen, giving bronchodilators, instituting pulse corticosteroid therapy. In the hospital, that sometimes in the ER will be IV methylpred, but it could be oral corticosteroids. And then consider antibiotics when they're appropriate. We'll talk about the antibiotic use in the acute exacerbation of COPD in a couple of minutes. And whether or not they need non-invasive medical ventilation, maintaining fluids, putting them on VTE prophylaxis pharmacologically, and looking at their comorbid conditions of heart failure, pulmonary embolism, ruling that out, that kind of thing. And then when you're managing exacerbations, the way we do this are with inhaled bronchodilators. You could use a beta-2 agonist or a short-acting antimuscarinic. We look at systemic corticosteroids pretty religiously. And we will look at antibiotics when they're indicated, particularly when there's purulence and increased amount of sputum or significant dyspnea. But Purulence and increased volume of sputum, or purulence and dyspnea are, or all three, are usually indicators for antibiotic use. Methylxanthines are not recommended. We don't use theophylline really hardly at all because the side effects are too aren't worth the benefit. And then we look at non-invasive mechanical ventilation before more invasive venting process is done. The criteria for a medical intensive care unit admission are more severe, particularly with changes in mental status. A change in mental status for these individuals is a big deal. And that sort of prompts you to think you got to go to the ICU. The indications for non-invasive mechanical ventilation are listed here. And then they make recommendations for when you failed non-invasive ventilation, when is a patient a candidate for invasive mechanical ventilation. Discharge criteria, once they're in the hospital, and then what the follow-up is at 1 to 4 weeks, and then in the first 16 weeks of therapy, sort of recommendation for follow-ups. The GOLD guidelines do that. They make recommendations that can affect or reduce the frequency of future COPD exacerbations. Let's spend a moment on this. Clearly, the bronchodilators offer some benefit, particularly the combination of LABA and LAMA together over individually alone. Corticosteroid-containing regimens, inhaled corticosteroids, and again, it's pretty much going to be the LABA, LAMA plus inhaled corticosteroid, particularly for those patients who have a high eosinophil count. The addition of a phosphodiesterase inhibitor in severe cases, that's probably a pulmonologist decision. Giving vaccines, definitely. Long-term macrolides like azithro, primarily in former smokers, and that again is likely going to be a pulmonologist decision. Mucoregulators make sense. N-acetylcysteine is pretty hard for patients to tolerate. Guaifenesin, pretty common to consider. And then clearly smoke cessation, pulmonary rehab, some other options that are listed here as well. The common factors you have to think about with all of these folks, most of them have had either a smoking history or a pollution or environmental or employment-related exposures that might increase their risk for lung cancer. So you need to be thinking about lung cancer as part of that mix. And then in COVID, they talk about the issues for COVID, which is true for everybody, but somebody with COPD, COVID is a more complicated with a more dire outcome for them. So you're looking at adequate public health strategies that would do for anybody with COVID, but make sure their vaccine status is up to snuff. They also make some specific recommendations and interventions associated with patients who either are at risk or do have some degree of COVID and where that fits. And then the specifics with COVID they recommend are what's done for COVID testing, pharmacotherapy that's used, non-pharmacotherapy, protective strategies, and the role of antivirals and corticosteroids is the primary approach. The use of other therapies, including interleukin-6 receptor blockers, different monoclonal antibodies, those are not routinely used. They were maybe more so a year ago. We still occasionally see them used in the hospital setting, but not very much. And finally, they look at having a process or a checklist with your COPD patients that you're able to kind of keep ahead of all of it. Finally, let's go through acute exacerbations of COPD. When there's acute exacerbation, folks will often have dyspnea, cough, and increased quality and purulence of the sputum. So you're going to make the assessments as is appropriate for their acute exacerbation of COPD. You're going to look at what our interventions are. As we alluded to, they're going to get bronchodilators. They're probably going to get oxygen. They're going to get really pulse corticosteroid therapy. And then you're going to think about, is it infected? Do they need an antibiotic? So the pathogens you're thinking of for bacterial infections are the same three we see in otitis media and we see with sinusitis. It's strep pneumo, Haemophilus influenza, and Moraxella catarrhalis. If they are gold category 3 or 4, or they've had a lot of pulmonary manipulations, you may also consider Pseudomonas. And you're considering the three cardinal symptoms that suggest antimicrobials: purulence, increased sputum volume, and dyspnea. And then if they have purulence plus one of the others, that's also okay in most people's uh, game plan to go with antibiotics. The empiric options depend on if you need to cover Pseudomonas or not. If you don't need to cover Pseudomonas, the agents I see patients use the most often, you could use amoxicillin clavulanic acid, which augmentin, that does a good job. You could use azithromycin, although there's strep pneumo resistance developing, so you're worried about that. Doxy works pretty well. Doxy is a reasonable choice here, and we see clinicians do that a lot. If they're a Pseudomonas risk, then we often see patients get high dose levofloxacin. Those are folks who are a candidate for pseudomonal coverage, as well as levo will cover as a respiratory fluoroquinolone, covers strep pneumo well, plus it also covers H. flu and Moraxella catarrhalis. And then finally, here are some drugs to consider that in your clinical year, you should have a little more familiarity where you recognize what a typical regimen for these therapies might be.